Hi everyone. Myself, Dr. Aparna. I'm taking care of the neonatology unit at Kim's Cuddles, Kondapur. And today I'm going to discuss about some suggestions and expectations when you do your case presentations in the practical exam. This is primarily with regards to neonatology, but you will find some of these tips useful for case presentations across pediatrics. So the usual cases that you get in your neonatology case, clinical case presentation may include a baby on respiratory support, a growing preterm or a low birth weight baby, or just a normal newborn. So when we talk about an acute case or acute neonatology case, this is usually a baby who is sick and who is on respiratory support, which may be either in the form of invasive ventilation or non-invasive ventilation in the form of either CPAP, NIPPV, HFNC, or a baby with asphyxia requiring therapeutic hypothermia. Or you may be having a baby with shock or multi-organ failure requiring peritoneal dialysis or a surgical newborn. The course or the sequence of taking the examination will include a short, brief history and information that is available from the baby's identity card, which includes the date of birth, the time of birth, the mode of delivery, etc., and the identification parameters like the mother's name. You will generally get around 10 to 15 minutes for a clinical examination. You must spend some time in observing the baby's movements, observing the baby from a distance, which may or may not involve palpation and direct examination, because the power of observation can be extremely vital in gathering some critical inputs, and start from the least disturbing points to the most painful aspects of examination. And also remember that while doing this observation, you yourself might be under direct observation of the examiners. Now, the most useful here is, do not treat exam as something special. Rather, exam should be an extension of your routine presentation on rounds. And in order to do this, you must treat your everyday routine examination or everyday routine presentation in rounds as your exam. So if you actually do this, then your exam is going to be a cakewalk. The next important aspect is the assessment of the environment, starting from the radiant warmer or the incubator. Understand or observe the mode of heating that the baby is receiving, or the heater output or probe, and start with the ventilator settings, preferably keep this for later. But start from the mode of ventilation and other subtle aspects like the mode of humidification, whether it's a servo control humidifier, whether its humidification is appropriate, whether the baby is receiving infusions, what is being monitored, what are the vital parameters being continuously monitored, and if the baby is attached to any other devices like therapeutic hypothermia or phototherapy. So, a close observation of the paraphernalia of the baby can give you a lot of vital information. For example, is the baby on an incubator? So, this could mean that the baby is an extremely preterm baby. And if so, you can also try to understand what is the heater output required in order to maintain the baby at a normal temperature. Then you try to understand vital parameters like temperature, heart rate, respiratory rate, the pulse volume, as well as saturations, blood pressures in all four limbs, glucose if not done earlier during examination, as well as some additional parameters like perfusion index, invasive blood pressure, and alarms. So you constantly look for the vital parameters, starting from the heart rate, respiratory rate, blood pressure, temperature, and the saturations. Note that one should use the correct size of the blood pressure cuff while checking the blood pressure. And in some cases, like suspected coarctation, you may also have to check four limb blood pressure or not just blood pressures from one limb. One of the most important additional examination that we do in a newborn baby, particularly in the first 96 hours, is gestational age assessment. Gestational age assessment is available from the first trimester ultrasound. This can be done using also can be done with a reliable history if we have reliable last menstrual period that is available, or from a T1 ultrasound. From in terms of the physical examination, we have various parameters like the new Ballard score and some other parameters like Perkins score, etc., for assessment of the gestational age. So these are some of the aspects that we test during the gestational age assessment. There are some neurological parameters and there are some physical examination parameters. So in terms of the neurological parameters, we assess the posture, and in the upper limb, we look at the square window, the degree of arm recoil, as well as in lower limb, we look at the popliteal and the angle and the heel to ear, and the scarf sign again for the assessment of the shoulder tone. Now, having finished vital signs and the assessment of gestational age, we move on to general physical examination. In general physical examination in a bigger child, we all often remember the mnemonic of pickle, like pallor, icterus, cyanosis, clubbing, edema, and lymphadenopathy. In general physical examination in a newborn baby, we probably may not lay equal emphasis on the pickle parameters, but instead you look at the baby's overall posture. Posture is an important indicator of the passive tone of the baby and the baby's color. Likewise, also on the anterior fontanelle, the sutures, and the shape of the skull, and the extent, if there is any dysmorphism that is present or any neurocutaneous markers that are present. In newborn babies, it is important to examine the baby's umbilicus and the external genitalia, and to understand the nutritional status of the baby by doing a gross physical assessment of the extent of subcutaneous folds, etc. And sedation score, just like you have the Glasgow Coma Scale in a bigger child, you may have to just assess the baby's neurological behavioral state using the Prestrel's or Brazelton's state. And we look at the integrity of the skin, try to assess the number of pricks that the baby has had, and if wherever possible you can try to understand the skin integrity in specific regions, like understanding the nasal injury because of CPAP. And one also has to carefully examine for the presence of any indwelling foreign bodies like central lines, umbilical lines, PICC lines, urinary catheters, chest tubes or intercostal drains, intravenous lines, peripheral lines, etc. In terms of the respiratory system assessment, one needs to count the respiratory rate, the breathing pattern, the extent of chest indrawing and grunting, the presence of ali, flaring of the nasal ala, and lability of saturations, as well as the presence of synchrony with the ventilator. So there are some objective respiratory distress scores that are available. This is the Downey score, which takes into account 5 parameters: respiratory rate counted for 1 full minute, retraction, cyanosis, audible grunting, or grunt audible with a stethoscope, and air entry. Based on the assessment of each of these 5 parameters, we assign the score of either 0, 1, and 2, 0, 1, or 2 to the baby. Alternatively, we can use the Silverman-Anderson score, which also works on similar lines like the Downey score. The only difference being that the parameters in Silverman score do not include the respiratory rate. They rather include upper chest, lower chest, and xiphoid retractions, nasal, the dilatation of the nares or flaring of the nares, and the presence of expiratory grunt. Again, the baby can be scored 0, 1, and 2 for each of these scoring items, which amounts to a total score of up to 10. One needs to describe the respiratory support that the baby is getting in terms of the mode of support the baby is getting, whether it is SIMB or SIPPV, the trigger that is being used, what is the set versus the delivered parameters, the interface that is being used, whether it's an endotracheal tube, the mask, or the prongs, the extent of humidification in terms of temperature being used, whether there is any condensation in the expiratory limb, pulmonary graphics, alarms, etc. And we also describe the nursing care of a ventilated baby in terms of the VAB bundle that is being practiced. What is the ET position? Are there any secretions in the endotracheal tube? Do you find appropriate humidification being used? And whether all supplies required for sterile suction are present. In the cardiovascular examination, note down the pulse volume, whether there are differential pulses that are palpable in the upper and the lower limb, differential saturations, what is the status of the perfusion as indicated by parameters like capillary refill time, and the presence of precordial activity, apex beat, etc. And abdominal examination would include noting whether there is any distension and describing whether there is any feeding intolerance. Now, to complete the overall assessment, we need relevant history. So based on the case that you are getting, You may have to elicit relevant history from the maternal history, from the family history, the important aspects from the birth history, etc. Also note the changes during examination and your response. So while going through a systematic proforma, do not hesitate to make small deviations as and when your baby shows some changes in the vitals. For example, while you're doing, let's say, gestational age assessment, if you find that the baby develops an episode of apnea or the baby develops desaturation, you would obviously have to pause during examination and focus on stabilizing the baby, which might mean positioning the baby appropriately, or where needed, giving tactile stimulation, or you may actually even end up starting some respiratory support. Focus on hand hygiene. No examination can be accepted if it violates or breaches asepsis and results in contamination or introduction of infection to the baby. And also remember that examiners want to always know whether you are well versed with the basics of essential newborn care, like breastfeeding, use of mother's own milk in the NICU, kangaroo care, developmentally supportive care, etc. These may not be sophisticated concepts, but these underlie some basic core principles in neonatology, and mistakes or inadequacies in these aspects are generally considered unacceptable. Wherever relevant, ask for relevant investigations like the last chest x-ray or the last blood gas. Like when you're dealing with a ventilated baby as acute case, don't hesitate to ask for the last blood gas and chest x-ray, because this completes your assessment of adequacy of ventilation. At the end of the history, the examination, both the general physical and the systemic examination, as well as relevant investigations and a holistic assessment of the other relevant details, you reach the provisional diagnosis, and you may give a list of differential diagnosis. For example, if you are dealing with a baby with respiratory distress, you may want to give differential diagnosis in the form of, if you think whether this is TTNB, or you think this is early onset sepsis with pneumonia, do you think this is bronchopulmonary dysplasia in a growing preterm, in pneumonia or meconium aspiration syndrome, with the appropriate points favoring and points against these differentials? And support your differential diagnosis with appropriate investigations, and summarize the plan for the day. Wherever you are asked to counsel families, remember the greet, ask, listen, praise, advise, and check mnemonic. Now, when it comes to some relevant aspects in disease specific cases, in any preterm, do not miss history on antenatal steroids or magnesium sulfate coverage, the history of care that is given at birth, risk of infection, do dwell into the cause of prematurity, most likely in that case, as well as on lung protective strategies. In a baby with term respiratory distress, you may have to describe whether the baby had history of asphyxia, meconium stain like anomaly scan, the risk of sepsis, care provided at the time the baby was born, and PPHN. And in disease, in cases relevant to neurology, then you may have to elicit whether there was history of asphyxia, or whether there were systemic manifestations of asphyxia other than the neurological involvement, like myocardial involvement, renal injury, etc., and about details of therapy like therapeutic hypothermia. You may also get surgical cases like tracheoesophageal fistula, diaphragmatic hernia, post-op, where we may have specific areas on pain management. So these are cases where examiners might ask you about pain scores, pain management, and about antenatal scans, about prognostic features based on antenatal scans, and the details of surgery. In addition, these are some core areas of focus. These are some areas of history in different diagnosis. For example, in a baby with sepsis, it's important to elicit maternal risk factors like intrapartum fever history, prolonged rupture of membranes or foul smelling liquor, and about the traditional some unhygienic practices like cow dung application on umbilical cord, etc. These practices can introduce infection in babies. Breastfeeding practices, and the details of antibiotics previously received, or family history of infections. In a growing preterm case, on the other hand, you may have to spend a lot of time in eliciting appropriate nutritional history and history of macro and micronutrient supplementation, and about growth charts. And one needs to also assess the adequacy of breastfeeding. In a case of a growing preterm, the additional areas of discussion will involve bronchopulmonary dysplasia, screening and follow-up of retinopathy of prematurity, and the routine screening needed for VLBW babies like metabolic screening, sodium, hematocrit, and follow-up care. And in terms of examination, we may look at vitals, anthropometry, general physical examination, and the systemic examination. So these are some classical spotters elucidating the importance of head circumference. On the left hand, you have a baby with very small head or microcephaly, and on the right side, you have a baby with hydrocephalus. So these are some important aspects in terms of anthropometry that shouldn't be missed. And wherever you have a growing preterm, also look into the trajectory of growth. In addition, one should not miss other relevant findings like obvious dysmorphism, facial phenotypic evidence of Down syndrome in the form of sloping frontal facial profile and the mongoloid slant. In the next picture, you have a baby with overlapping digits, which is often seen in trisomy 18. We may have a baby who has a severe variety of limb defects or acromelia or caudal regression syndrome, also called as a mermaid baby. We may have babies who have multiple hypopigmented lesions, which could be a part of a neurocutaneous syndrome like tuberous sclerosis, or you may have a baby with skin patches, which may be seen with the conditions like incontinentia pigmenti. So you have various findings based on these some of these markers relevant to dysmorphism. You may have a baby with asymmetric appearance of the palpebral fissure, where one has to rule out conditions like unilateral cranial nerve palsy. A good neurological examination includes assessment of sensorium, cranial nerve involvement, motor assessment in the form of the muscle tone, posture, power, as well as deep tendon reflexes, primitive neonatal reflexes like sucking, rooting, and sensory assessment. So these are all aspects of the neurological examination, the behavioral states, assessment of gestational age, and cranial nerve examination, higher mental functions. This is assessment of the passive tone, and this is assessment of the active tone, which is assessed by pull to sit maneuver, the shoulder tone, as well as ventral suspension, vertical suspension. These are the Amel-Thiesen's angles that are used to assess the passive tone of the lower limb using the adductor angle, popliteal, heel to ear, and dorsiflexion angle of the ankles. These are babies that demonstrate tone abnormalities. You have a baby with most likely with bilirubin encephalopathy having retrocolis and extensor hypertonia, and in the middle you have a baby with severe head lag, and on the right side you have a baby with a significant hypotonia with a ragged doll kind of appearance. So, for doing a good neurological examination, make sure baby is in state 3 or 4 with the head in the midline. Deep tendon reflexes, you must carry a knee hammer with you. Sometimes we also use a stethoscope for eliciting deep tendon reflexes, but do remember that even in newborn babies, common deep tendon reflexes like the knee jerk and the tendo Achilles jerk can be elicited, ankle jerk and the knee jerk. And general body movements or the spontaneous movements of the baby have been used for describing the neurological behavioral cues of the baby. Based on your holistic examination and presentation, you may expect multiple questions. Most of the common questions are from the antenatal management of the baby. For example, counseling for congenital anomalies or counseling for an anticipated preterm birth. You may have questions on delivery room management and on thermoregulation, breastfeeding, infection control, kangaroo care and family participatory care, newborn screening, immunization, routine well baby care, discharge counseling, ROP, etc. And some common resources you should read before your exams are the most updated NRP guidelines, WHO recommendations wherever they are available on neonatal care. For example, you have WHO low birth weight guidelines, seizures guidelines, CPG guidelines, and Indian guidelines. And do remember to brush up all the landmark recent trials. So these are some of the important books. So with that, I thank you all for the attention and good luck with your practical examinations, of course, as well with your theory examinations. But remember what I said about every day being an exam, every case being your best foot or your best attempt for doing your case presentation. And do not wait for your exam day to be your best day. Remember, try to think of every day as your exam case presentation day so that you can make the most of it. So, with that, I thank you all for joining and good luck. All the best for your exams. Thank you.